Good morning, everyone, and welcome to another TIRO by MDS webinar, where each week we bring together leading experts to discuss the latest advancements in thyroid cancer and thyroid research. I'm JP Brito, an endocrinologist at Mayo Clinic, and I will be your host. Today, we'll be focusing on the usefulness of the international grading system in the management of sporadic medullary thyroid carcinoma, and we are joined by two distinguished guests. Our presenter, Dr. Alessandro Prete, is pursuing his PhD at the University Endocrine Unit at the University of Pisa under Professor Rosella Elisei, where he completed his medical degree and endocrinology training as well. His research focuses on thyroid cancer biology from molecular mechanisms to clinical management, with a special interest in advanced cases with targeted therapies. He has served as an investigator in multiple clinical trials and actively contributes to international endocrine societies. Dr. Preti has co-authored more than 30 peer-reviewed papers and serves as a reviewer for several leading scientific journals. Our discussant is Dr. Bin Zhu, is the head and neck endocrine pathologist at Memorial Sloan Kettering Cancer Center. She earned her PhD at McMaster University and completed her MD and pathology residency at McGill University, followed by fellowship in surgical oncology and head and neck pathology at MSK. Before joining MSK, she was the head and neck pathologist at Sunnybrook Health Sciences Center, University of Toronto. Her research focuses on thyroid and head and neck cancers, and she authored more than 140 original research papers, as well as numerous reviews and book chapters. Please join me in welcoming Dr. Preti and Dr. Zhu today's sessions. We're going to start with Dr. Preti, that he will be starting with a presentation, and then the commentary and discussion will be by Dr. Zhu. So, Dr. Preti, the stage is all yours.
So, as first, I would thank you for being here because it's a great honor for us to be here and to discuss with you about our recent article. I will thank the THANC Foundation for their kind of invitation, and it's very important for us and to be included in this wonderful series of webinar. I would thank Dr. Brito for his kind presentation. So I have no financial disclosure to declare, but I want to declare that I'm not a pathologist, I'm a clinician. So my discussion will be about the grading in medullary thyroid cancer from a clinical perspective. I'm not a pathologist, so I will not focus on any pathological point of this grading system. Medullary thyroid cancer is a rare neuroendocrine tumor which arises from thyroid C cells, is a rare tumor, and we know that its prognosis is worse than papillary thyroid cancer and follicular thyroid cancer. We have recently reviewed the survival in our series of patients, and it's crucial to understand, to better stratify the prognosis of each patient. And what we know so far, we know that it's important to know if we are talking about a sporadic or an hereditary cases, because they have different prognosis and they have a different clinical management. Moreover, it's crucial to know the extent at diagnosis because we have to know the size of the tumor. We have to know if there is a minimal or a gross extracellular extension, lymph node metastasis, and distant metastasis. We know that distant cases have a lower survival compared to regional or localized cases. Another main point to stratify the prognosis is the genetic fingerprint of sporadic cases. We already published in the past that the RET-mutated cases have a lower prognosis compared to cases without RET mutations. And if we focus on RET mutation, we know that cases with RET M918T or RET Int'l mutations have a lower survival compared to other RET mutations. Nonetheless, we know a lot of things, but we still need new prognostic markers. And This space was occupied by grading, by this International Medullary Thyroid Cancer Grading System. It was proposed by this incredible group with many authors coming from many countries, and they build up this grading, this two-tiered grading system, which define two different grade, high grade and low grade tumors. High grade was defined in presence of a mitotic index higher or equal than 5, Ki67 proliferative index equal or higher than 5, and or presence of tumor necrosis. This grading system was showing to be associated with lower overall survival, lower disease-specific survival, lower disease distant metastasis-free survival, and lower local regional free survival. But when we evaluate a new marker, we should take in account multiple points. So, as first point, the proof of concept. And this article showed very well that patients with high-grade tumors have a lower prognosis compared to patients with low-grade tumors. And this is why it was endorsed also by the WHO. Then we should evaluate this marker in a prospective validation studies. However, medullary thyroid cancer is a rare tumor, so it's not easy to build a prospective study with many cases and long follow-up. So we have multiple retrospective data which confirm that the grading is a powerful prognostic marker. And then we should evaluate their usefulness from a clinical point of view. So we should evaluate its incremental value and its clinical utility. So does the novel marker add predictive information to the established standard risk markers? We are a clinician, so we decided to focus about this point, the incremental value added by this grading. The aim of our study was to evaluate in a large monocentric series of sporadic medullary thyroid cancer the performance of the international grading system and its clinical usefulness according to different disease extents, at diagnosis, and red status. So we analyzed 314 consecutive patients with sporadic MTC registered in a prospective maintained database. The data lock of the study was January 2024, and we involved two pathologists which were expert in medullary thyroid cancer diagnosis and which re-evaluated each cases to distinguish high-grade and low-grade tumor. And we were able to have somatic genetic analysis data in 212 cases, so more than two-thirds of all cohorts. Here, I want to specify that the research for somatic genetic mutation in medullary thyroid cancer was made for scientific purpose. In Europe, it's not mandatory the search for somatic genetic mutation, but we are a center with the possibility to perform somatic genetic mutation and to perform next generation sequencing in medullary thyroid cancer. So we have this data in many patients in more than two-thirds of all the cohort. We start focusing about the features of our patients. More than half were women. About the TNM, more than 60% were T1, both T1A and T1B. Lymph node metastasis was observed in about 30% of cases, and distant metastases were observed in 9.9% of all cases. If we evaluate the disease extent at diagnosis, a localized disease, meaning that disease confined to thyroid gland, was observed in 58.3% of cases. Regional disease, so disease involving the tissue surrounding the thyroid gland or regional lymph node was observed in 31.8% of cases, and the metastatic disease was observed in 9.1% of all cases. We evaluate the prevalence of local recurrence and distant metastasis in 283 cases. We excluded from this analysis patients who were already metastatic at diagnosis. And in a median follow-up of 79 months, we observe local recurrence in 35 patients and distant metastasis recurrence in 18 patients. The survival was evaluated in all the cohort, and we observed during a median follow-up of about 10 years that occurred in 28 patients. We applied the International Cancer Grading System in our course, and 36.6% of cases were defined as high grade, and 73.4% was defined as low grade. And then we associated this grading system with the clinical feature. So we observed that patients with high-grade tumors presented worse biochemical, pathological, and clinical features. Patients with high-grade tumors had higher preoperative calcitonin compared to low-grade. And if we move to pathological feature, as you can see, patients with high-grade tumors had larger size, higher T, they had higher prevalence of multifocality, higher prevalence of minimax extension, higher prevalence of lymph node metastasis, and higher prevalence of regional and metastatic disease. And if we move to the clinical features, local recurrence and distant metastasis recurrence were more common in patients with high-grade tumors, as well as death occurred more commonly in patients with high-grade tumors. But we would like to understand if and in which cases the grading had an higher incremental value in the SSFS and the MFS when we compare the grading to extent diagnosis. So we started analyzing the disease-specific survival, and we performed an univariate analysis. And we observed that both disease extent diagnosis and international medullary cancer grading were associated with disease-specific survival. But when we move to multivariate analysis, only the disease extent diagnosis persisted as an independent factor associated with disease-specific survival. Then we decided to evaluate in which cases grading could add more incremental value. So here you can we certify the patients according to the disease extent diagnosis. So on the left, localized disease patients, in the middle, regional disease patients, and on the right, metastatic disease. And as you can see here, none of them reached a difference which was statistically significant, but there is a small difference in localized disease cases. So in saying as that grading could be useful to identify the few patients which are dying in spite of their localized disease at diagnosis. Then we move to local recurrence-free survival. And at the time, both disease extent diagnosis and international medullary grading system were associated with local recurrence-free survival, both in univariate and multivariate analysis. Then we evaluate the usefulness of grading in a localized and regional disease. Another time, I want to highlight that we excluded patients which were already metastatic at diagnosis. And another time, the grading was able to identify those few patients which had local recurrence during the follow-up, in spite of their localized disease at diagnosis. About the regional disease, there is a difference, which is not a statistical different, but we think if we increase the number of patients, we could observe here a difference, which can be statistically different. Then distant metastasis-free survival. We evaluated the association between disease extent at diagnosis and distant metastasis-free survival, and grading and distant metastasis-free survival. Both of them were associated with DMFS, both at univariate and multivariate analysis. And another time, when we stratify the patients according to extent at diagnosis, we do not observe any relevant difference between high-grade tumors and low-grade tumors in both cohort, localized and regional disease. Here again, about the regional disease, highlight that maybe if we increase the number of patients with, we could reach a difference that could be statistically different. Then we move to evaluate the incremental value in DSS, LRFS, and DMFS, comparing grading and genetic fingerprint. As already said, we have the genetic data in 212 cases, which is more than 2/3 of all cases. And in this cohort, high grade was more common than the whole cohort. High grade was defined in 46.7% of cases and low grade in 53.3% of cases. RET mutation were observed in 54.7% of cases. And if we compare the genetic fingerprint between low grade and high grade, we observe that in high grade, we have an increased prevalence of RET mutation. Moreover, among the RET mutation, we observe that in high-grade tumors, we have an increase of RET M918T mutation and RET Int'l mutation, which have a lower survival compared to other RET mutations. We evaluate in univariate and multivariate analysis the association between the RET fingerprint and the grading. And overall, we observed that both the presence of RET M918T indels mutations and the high-grade tumor persisted as independent factors associated with the SS, LRFS, and the MFS. So now we stratify the patients according to the genetic fingerprint. So as first, we started with the patients with RET M918T or indels mutation, and we do not observe any difference which was statistically significant between high-grade and low-grade tumors. Then we move to other RET mutations, and here there is a difference, which is substantial but not significant, between patients with low-grade and high-grade tumors in DSS. And finally, when we move to cases without any RET mutations, we observed that grading was patients with high-grade tumors at the lower DSS and LRFS compared to low-grade ones. So going to the discussion part, we confirmed that high-grade medullary thyroid cancer showed a worse disease extent at diagnosis compared with low-grade ones, as well as other negative prognostic factor, IRT and M-stage, minimal axillary extension, and multifocality. When we stratify the patients according to their disease extent at diagnosis, having high-grade tumor was significantly associated with lower DSS and lower LRFS only in the case of localized disease. In our series, RET somatic mutations were significantly more frequent in patients with high-grade tumors compared with low-grade ones. But interestingly, only in patients without any RET mutation, the grading system was able to identify those few patients with worse prognosis. In conclusion, in our large cohort of sporadic MTC patients, we confirmed the overall reproducibility of the international medullary cancer grading system, since patients with high-grade tumors had a lower DSS, LRFS, and DMFS compared with low-grade. However, this was clinically relevant mainly in patients with an apparently lower risk of recurrence and mortality, so patients without any other significant prognostic marker, for example, lower stage at diagnosis or RET negative cases. Conversely, when lateral cervical lymph nodes, distant metastases, or RET mutations, particularly AMN1T or Int'l mutations, were already present at diagnosis, the role of grading in predicting DSS, DMFS, and LRFS become less relevant. I will conclude thanking for your attention and thanking all the authors for their effort in this article, in particular Antonio Matrone and Rossella Letsei. Thank you.
Thank you, Petri. We will pass it to Dr. Zhu. Sorry.
Thank you. So thank you for the invitation and thank Dr. Brito for the kind introduction. So for the next 10 minutes or so, I'm just going to be focusing on the key findings of the paper and discuss the paper in the relevance of available literatures. I have nothing to disclose. So basically, as Dr. Prete already mentioned, is a large retrospective cohort focusing on only sporadic medullary thyroid carcinoma. Among them, a decent amount of cases have a next generation sequencing on RET mutations. The follow-up is decent as well. The median follow-up is 79 months, and the longest follow-up is 248 months. And the key outcome they're studying is disease-specific survival, local regional recurrence-free survival, and distant metastasis-free survival. So what is grading in medullary thyroid carcinoma? Dr. Prete already mentioned that we published international collaboration to establish a grading to separate medullary thyroid carcinoma into two grades. Basically, the high grade have a high mitotic count, high Ki67 proliferation index, or tumor necrosis. What Dr. Prete found in his study is that grade basically correlate with disease extent, or we can interpret it as initial stage as a diagnosis. High-grade tumor is more prevalent in high T stage, high N stage, and high M stage tumors. And if you can see the disease extent in the presentations, in localized disease, the high-grade tumor is only 22%, while it's increased to 51% for patients with regional metastasis, and the increase for even more in patients with distant metastasis to 77%. This is actually quite compatible with our initial study, where we show that grade correlate with distant metastasis presentation and AJCC stage 4 disease, which include T4, N1B, or M1 disease. Dr. Prete and it all continues to do survival analysis. What they found is on multivariance analysis using both grade and disease extent. They found grade is predictable, independent predictors for local regional recurrence-free survival and distant metastasis-free survival, but not disease-specific survivals. Stage is predictive for all three outcomes, and they didn't include any other factors in the multivariate survival analysis. This is similar to the initial study we did, where we found that grade and stage are predictive of all outcomes, including overall disease-specific, distant metastasis, and local regional recurrence-free survival. And we are able to throw in other clinical pathological factors such as postoperative CEA, age, and so on and so forth. So the fact that grade is prognostic in medullary thyroid carcinoma have been validated on multiple cohorts from multiple countries. And here is just a list of all the studies from Italy, India, US, multiple centers, and China. And in red, those have multivariance analysis and shown that grade is predictive for outcome. And more specifically, the two recent studies, one from Italy and one from China, actually show that grade trumps stage and red mutations are not significant on multivariant survival analysis in predicting outcome. So clearly, we have an interaction between grade and stage and outcome in medullary thyroid carcinoma. Both Dr. Prete studies and other studies have shown that high-grade medullary thyroid carcinoma is associated with a high stage diagnosis, that including P-stage nodal metastasis, distant metastasis, and AJCC stage group. Most people, some studies show stage or disease extent independently predict outcome, that including this study and the initial study we did. But this is not repeat in all studies. Some studies do show that stage is not independently predict outcome. Grade also have controversial data. Well, some studies showed grade independently predict outcome, while this current study show that grade only predict local, regional, and distant metastasis-free survival, but not disease-specific survival. I think one unique feature of this current study, they actually do substratification to look at the interaction between grade and different stage of tumors. What they found is that when patients have local disease only, grade does predict local regional recurrence-free survival. As you can see here, it is significant, but the separation between the high-grade and low-grade tumor are actually not as apart. Well, when you look at the regional patient with regional disease, means they have nodal metastasis, there are a bigger separation between the high-grade tumor and low-grade tumor. However, the p-value is not significant. As Dr. Prete mentioned, this could be due to a smaller number of cases, and when the case number increases, the p-value might decrease to significant levels. Very similar to the grade and stage story, there also an interaction between grade and red mutations in somatic medullary thyroid carcinoma in the current study. What Dr. Prete et al. Have shown that high grade was associated with a high frequency of red mutations and more high-risk red mutation being M9118T or Int'l. They also show that red somatic mutation independently predict outcome, and red high-risk mutations also independently predict outcome. In terms of grading, they throw in a multivariate analysis using grade and red mutation, and they found that grade independently predict outcome as well. And here is their data basically showing that both grade and the red mutation status is prognostically relevant. And the high-risk red mutation is also prognostically relevant. So to date, there are not many studies actually have both red mutation data and outcome and grading together. There are only 3 papers published so far. One is this study, and 2 published last year by our group and by an Italian group. The data you can see is not always consistent. All 3 studies have a large amount of cases, and all 3 studies show that red somatic mutation is associated with grade, but the high-risk red mutations is only associated with grade in the current study and the other Italian study, but not in our multi-center cohort. All 3 studies showed red somatic mutation was associated with outcome, and but in terms of the red high-risk somatic mutation, one study being current one showing it's associated with outcome, and our study failed to show that red M9118T is associated with outcome. And in terms of grading, predict outcome independent of the RET mutation status. Current study didn't show it, but the other Italian study and our multi-center cohort does show it. So you can see the interaction seems to be more controversial, and the result is not very confirmative on all studies. So get back to the study. The key study, as Dr. Prete mentioned, is to confirm the prognostic significance of the grading system. Being high-grade medullary thyroid carcinoma is associated with decreased outcome, decreased survival. And the author also mentioned that grade appears to be clinically relevant only in patients with low-risk medullary thyroid carcinoma, meaning have a low stage, localized disease, or a right white type phenotype. When it's becoming higher stage, being N1 or M1 or red high-risk mutations, grade becoming less relevant. But this may be due to a lower number of cases in the study due to substratification. The pro and cons of the study is a large cohort composed of more than 300 of patients, and among them, more than 200 have red mutations. So it's a really good size retrospective study with a decent follow-up. They do perform both multivariate survival analysis and substratifications. The cons, as Dr. Prete already mentioned, is retrospective in nature, but like most study in medullary thyroid carcinoma, unless it's a clinical trial, it's hard to be prospective in nature. And then the significance of substratification into subgroup analysis may be limited by the case in each stratum. In conclusion, we can draw convincing conclusion from this study and from what's available in the literature that grade is prognostically relevant for medullary thyroid carcinoma. And there is clearly an interaction between grade, stage, right mutations, and other prognostic factors that may be explored in larger scale study or prospective studies. In the end, all this multifactorial analysis have its limitations. Eventually, maybe like differentiated thyroid carcinoma, we should move towards a risk stratification or prognostic nomogram as a solution to better risk stratify medullary thyroid carcinoma patient. Just an honorable mention, we did a prognostic nomogram and initial risk stratification using our cohorts, and it's published last year. But unfortunately, at that time, we don't have the red data, so we only have stage, grade, and other factors to predict disease-free survival, and it's available online if anybody want to play this. That's it for the discussion.
Oh, that was wonderful, Dr. Petri and Dr. Zhu. Thank you very much. I think this is a very interesting topic. We will be getting the questions in the chat, but in the meantime, I can tell you that I do struggle a little bit from a clinical perspective, also as a research and design perspective of the studies that had been done in this area. But let me start with the clinical question. So I am a clinician, I'm an endocrinologist. I have a patient that had medullary thyroid cancer. It's sporadic. I might or might not have the genetic results. I do have preoperative calcitonin. I might even have postoperative calcitonin. I do have the extent of the disease, and probably going to have the grading now with low and high grading. How do I combine all of them? And in the combination of this, how that helped me in following my patient and next steps? So let's start with Dr. Preti and then Dr. Su.
Thank you for your question, Dr. Brito. So I think we should put together all the pieces of what we have. I mean, we know that patients with distant metastases have a lower prognosis, and this is a very powerful indicator. My feeling is that we are more or less talking about the same kind of patients. I mean, patients with distant metastases have also high-grade tumor, have also a 918 mutation, so they are all together more or less in the same patients. So my feeling is that we are talking about the same cohort of patients. So when we have a new marker, and we should increase our experience to use this marker. So maybe in distant metastatic patients, they have a lower have a worse prognosis, and maybe there is not a big incremental value to know or not the graded system. On the other hand, when we do not have anything, so for example, localized or maybe also in a regional disease, knowing the grading could be useful to better stratify the patients and to better stratify also the clinical management during the follow-up.
Appreciate it. Dr. Shu, any
Yeah,
comment?
I would really think it's really that's why I think we should move towards a risk stratification strategy using all the known prognostic factors. As you mentioned, the stage doesn't matter, the grade is a new marker and it's proved to be working. You might have post-op CEA or calcitonin, so all this have to be entered into consideration for treatment and follow-up. So it's I think eventually it will be multifactorial, moving towards a risk stratification for this patient to decide on management.
So that's helpful. So we are seeing that there is a lot of interaction among these markers or information that we have, some overlapping. And I think the solution that I'm hearing from both of you to some extent is it has to be combined, and maybe even in research it could be combined with a risk stratification systems that combine all those factors and presents a score, or similar to what we do in differentiated thyroid cancers, low risk, high risk, intermediate risk, that really drives a little bit of the follow-up. So it's an extra piece of the equation, how to re-stratify these patients, but we still don't have the what exactly that means in risk. But that it seems that it's coming. The Dr. Prete, you do mention, and I think it's an important finding, is that let's see that you have a patient that has localized disease, doesn't have regional disease, but he has necrosis, or that has mitotic rate and is high grade. How do the clinicians should change or follow up these patients?
Actually, it's not easy to answer to this question because we do not have any data about this point. What I can say is that maybe we can see more frequently these patients. So medullary thyroid cancer is very different from differentiated thyroid cancer. In differentiated thyroid cancer, we can also use a radioiodine that we could use another marker to decide yes or no radioiodine. In medullary thyroid cancer, we do not have this weapon, this possibility. So the main thing we can do is, as first, for example, change the clinical management so we can see more frequently the patient, or imagine a patient with localized disease, but with an high-grade tumor. We can decide to perform a rat somatic mutation earlier than expected. So this could be another point that we can think about.
Okay, very helpful. Now, this is a piece of information that many healthcare systems are probably going to try to adapt, many pathologists trying to adapt. Tell us the challenges, Dr. Su, in regards of the the variability in regards of how we different pathologies classified or or ascertain the necrosis or the mitotic rate. How reliable is that one pathology gets it, or how unreliable might be in regards to the inter-observer variability?
We actually they are actually study done by pathologists because the grading parameters KICC7, which is objective measures, and mitotic count, which quite objective, and tumor necrosis, which is quite defined in pathology world. So there are study actually show it's quite reproducible. And the KIC7 can be used by eyeballing, by deep learning models, by digital analysis, and all of them have quite consistent measurement. So I would say it's reproducible. I didn't mention even in this study, there are two pathologists. They evaluate them independently, and most of them are concordant. And it was only 10% of cases that they eventually reach consensus. So I think it's reproducible and it's quite objective in terms of the pathology valuation for grading.
That's helpful. So it's quite reproducible, and it seems the artificial intelligence also is helping in getting if I understand mitotic counts is
We are not there yet for
not
mitotic.
yet there.
Yeah, 67. Yeah.
Okay, I-67. Okay. Why, by the way, why we're not yet there for mitotic? I know
Because
that other fields they do have it for mitotic counts.
Actually, yeah, here we have AI models. We try to do AI models mitotic count, but mitotic figure have different shape, so it's hard for AI to capture. On the other hand, it's just a nuclear signal, so it's easier for the AI just to capture the brown signal.
Okay.
Yeah, we're working on it in breast cancer, in melanoma.
That's
And
what I knew. Yeah, the breast cancer they have some interesting models there.
yeah.
So having said that, now we have the grading, we have the stage, we have all those pieces. What is going to be the contribution of artificial intelligence here? For instance, when Dr. Xu, you are building a risk classification system based on this information, are you considering adding digital pathology AI signals within this to see we can refine our classification task or prognostic task too?
As far as I know, there is no AI model for prognostication in medullary
Interesting.
carcinoma. There are, I think, Harvard have studied trying to predict the red mutation status in medullary carcinoma using AI, but it's not published. So I think we are too early to draw any conclusion.
Dr. Prete, is any work that you know in Italy in your group in regards to AI and digital pathology in medullary thyroid cancer as a way to improve our prognostic and predictive value?
So we are working about that. We are working about if AI can help us in diagnosis and also in the clinical management. But another time, I think it's too early to define its role in medullary thyroid cancer treatment. And unfortunately, we are talking about a rare disease. So, okay, we know that AI can in some way increase the capacity to analyze data. We can also in case of lower numerosity, but it's not easy to have a significant conclusion about that. So maybe a multi-center study with multiple center enrolled could be the way to understand if AI can help us.
Yep, very helpful. I do have a question from the audience. It's about the extent of surgery. So I will extend it to you, Dr. Prete, and it says thyroidectomy has been proposed as sufficient to treat small medullary thyroid cancers. So thyroidectomy for localized small thyroid medullary. Considering the high rate of somatic mutations seen in this population, would lobectomy leave a patient with somatic mutation and an acceptable risk for developing a second medullary thyroid cancer in the remaining thyroid tissue, especially if there is a red M918? A very good question.
Yeah. So as first, the multifocality in medullary thyroid cancer is not so common. So also in our court, it was more or less 10%. So, and many cases were observed in ultrasound. So it's crucial to stratify the patients before proposing the lobectomy. So the patient should have small intrathyroid nodule without any sign of other nodules in the other lobe. And the other point, of course, we should not propose lobectomy to patients with red germline mutation, because in this case, we're talking about about patient who will develop medullary thyroid cancer also in the other lobe. So my feeling is that multifocally could be a small problem in this setting because many cases could be observed by ultrasound before the surgery. And if we observe the appearance of another nodule on the other lobe, we will take care during the follow-up. There is no rush to propose thyroidectomy directly. Of course,
Okay.
lobectomy plus lymphadenectomy of the side,
Central?
the
Yeah.
central compartment. Yeah.
Well, I see Dr. Shaha here, and since we're talking about, do you mind if I ask a question?
Go ahead,
Dr.
sure.
Shaha? Lobectomy for clinically unilateral
Yeah.
MTC. What is going on there in Memorial?
Well, let me put it this way. We strongly believe that if the tumor is encapsulated and there's nothing on the other side, and the calcitonin is not sky high, lobectomy is a good choice. And the reason behind that is the possibility of developing cancer on the other side is less than 5%. But the quality of life is excellent. Now, there is always a debate, should we wait for the molecular testing, the genetic testing to come back, and then plan the surgery? Even though in practice that should be done, most of the patients don't want to wait 3 weeks to get the genetic testing. They want the surgery next day. So if the metanephrines are normal, that means there is no pheochromocytoma, we feel it is a sporadic disease. Also remember, if there are no suspicious lymph nodes in the central compartment and lateral neck, lobectomy is very ideal as long as, because you can monitor the patient with calcitonin. Suppose after the surgery, the calcitonin is still high. That means either there is a nodal disease we missed or there is something on the other side.
Yeah.
And the possibility of something having on the other side, if the ultrasound is normal, is very small. James Wu wrote a paper from UCLA recently about sporadic medullary cancer and lobectomy only. Akira Miyauchi from Kobe, the person who has popularized active surveillance, wrote a paper in 2010 suggesting a lobectomy. And me and Mike Tuttle, we wrote an editorial about the same subject. James Wu is planning to do a multi-institutional prospective study. But you know the IRB and everything, it takes a long time. But am I comfortable? Yes, absolutely.
Appreciate that. Dr. Prete, you have your hand
Yeah.
raised.
May I add something?
Yes, of course.
Yeah, I totally agree with Dr. Shah. I think that we are lucky because in medullary cancer we have calcitonin. So we can follow up the patient with after lobectomy with calcitonin. However, we should understand the threshold of the calcitonin with lobectomy. So it's another point that we should increase our experience and to use this marker to follow up the patient with lobectomy. So
Yeah.
I
It's
totally
also trending, It's not one calcitonin.
Yeah, of course.
So trending. Suppose now this is 10 now, and in 6 months it is 100. We know there is medullary thyroid cancer.
Yeah, of course, of course.
So, and we are also moving in that path. I will say that more conservative surgery for a small unilateral medullary thyroid cancer. Now, let's see, you do surgery and then you remove the tumor and it happens to be high grade. What would you do? I mean, the issue is reporting this is a localized, it is even not even multifocal, but it's high grade. So will you do total thyroidectomy? And what is the goal of that, for instance? Let's start with you, Dr. Prete.
Yeah, in our data, we observed that the grading was very useful in a localized disease, but the risk to have a recurrence in localized disease is very low. So I think we should not change our treatment. We should follow up the patient. Maybe we can think that if we should more frequently see the patient, but we should confirm the lobectomy, and then by ultrasound and calcitonin trend, we can decide what we will do.
Dr. Shaha, any thoughts about that?
No, I think Dr. Preet said it very well. Let me just go back. Let's say you take out the tumor and it is high grade. what's going to happen to this patient? More likely local recurrence, more likely nodal recurrence, which Dr. Preet mentioned that we should follow very carefully. And if we find something, take care of it. By taking out the other side, we're not going to change this. The risk of local recurrence in the one lobe cannot be changed by taking out the other side. The risk of nodal disease, either in the central compartment or lateral neck, cannot be altered by taking out the other side. By taking out the other side, we feel, and the patient feels, we had a big operation, the quality of life suffers. Let's say this patient is 30-year-old. He or she is going to suffer for next 70 years with 2% risk of complications and 100% need of thyroid medication. So we need to put in perspective why we are taking out the other side.
Yeah, very helpful. Now, Dr. Shu, let me ask you something. So, when we travel, when we see, even within the United States, outside United States, this grading is not yet used, and many institutions have not been implemented, and we do see the value. I mean, we do see that as another data point that we can use. Why do you think is the problem of not being widely implemented?
Actually, I think it's probably because it's recent, but it's already endorsed by the WHO, and it's incorporated into our reporting guideline in North America. So the College of American Pathologists endorsed it and mandated reporting of Ki67 tumor necrosis and mitosis now for medullary thyroid carcinoma. So I think it's coming. It's just a slow process.
Yeah, so it's just a matter of time to.
Yeah, exactly.
Do you see similar to for instance, for high-grade papillary thyroid cancer or poorly differentiated thyroid cancers, do you see people disagreeing with this in any way? So just looking at the necrosis versus the mitotic rates, do you see the pathologists coalescing in a common opinion, or do you see many other pathologists perhaps disagreeing in how we should take on these markers?
I think once it's endorsed by major guideline like WHO classification and our reporting pathology guidelines, it starts to be incorporated by all the pathologists, at least in North America. I think this high grade and poorly differentiated thyroid carcinoma is also a new change, but it's coming, and we start to incorporate it. I see most of the places start to incorporate it in North America at least. Yeah.
Very helpful.
It's a slow process, but it's going there.
We will get there. So the last question, Dr. Su, is so what is the next study? You described that a risk classification system might be in medullary with grading, with the staging. So how does a study look like?
We are not having any planned study, but I envision this to incorporate multiple centers. I don't think prospective study is the easy way to go, so most likely retrospective in nature, and to just validate and develop a bigger cohorts that can validate the prognostic value for all this clinical, molecular, and pathological parameters, just like a differentiated thyroid carcinoma.
Yeah, but you see that's interesting. You see that's a normogram. So you see to some extent even a point system, a weight system in which the calcitonin preoperative has a value, the red has a value, the grading has a value, the staging has a value, and then a composite score of what it will mean in terms of the risk of cancer coming back. Do you foresee that happening in the near future?
Hard question to answer. Or is stratification like differentiated thyroid carcinoma will do? I think it's coming because we now know there's so many prognostic factors, and they have to be incorporated one way or another into clinical management for risk stratification. As it's coming.
This is fascinating. So, well, first, thank you, Dr. Prete. Thank you, Dr. Su, and Dr. Shah, as always. Thank you for your wonderful comments. Before we wrap up, I just wanted to bring to your attention our podcast, the Voices of Wisdom. is dedicated to medical professionals in thyroid cancer treatment. Each month, we explore expert insights and groundbreaking research. So please catch this episode. It happens the third Tuesday of every month, and you can find it in your favorite podcast, Apple, Spotify. So tune in and follow up on the podcast today, if possible. Also, to extend an invitation for the next webinar is Dr. Iwao Sujitani going to be talking about the long-term outcomes of active surveillance with low-risk papillary thyroid cancer, and the discussion will be with Dr. Toro from Memorial. So again, join us. And again, thank you very much to our fantastic panelists. Appreciate it.